morning again. I'm Bleddyn Rees. I'm the chair of the Digital Health Society, and I'm going to hand over to Dipak Kalra to give the first introduction to this panel.
Well, good morning, everyone. Yes, my name is Dipak Kalra from the European Institute for Innovation Through Health Data, and what I'm going to be doing is sharing with Bleddyn the running through of a session this morning, which has been an enjoyable double act between our organizations over the past couple of years. But before I go into the detail with him, I'd like to introduce you to our panel. So firstly, Elena Bonfiglioli, who is the Regional Business Lead for Health and Life Sciences within Europe, Middle East and Africa for Microsoft. Then we have Nigel Hughes, who is the Scientific Director for Observational Health Data at Janssen R&D and also the project lead for EMEA Eden, a European project focused on big data. And then I have Jesper, who is the Director of the Data Analytics Center for the Danish Medicines Agency. So you can tell that I have three panelists who are very, very passionate about health data and health data at scale. So I'm going to hand back to Bleddyn first to tell us why we are here and how we got here. So Bleddyn, over to you. Thank you.
Thank you, Dipak. And hopefully now everyone can see the slides. So first of all, a little bit about this big health data opportunity. So why did we start the roundtables in the first case? Well, it was this massive exploding data opportunity extending from care to the research spectrum. But Dipak and I were concerned that this development was moving slowly and needed to be accelerated. And as you can see on the slide, we were talking about the growing need for large-scale access to health data from electronic health records, patient and citizen-generated data, medical device data, and then non-health sources data such as environment, transport, for example, pollution data. This data needed to be fine-grained, individual, not only aggregated, and close to real time. For this to be longitudinal to deal with health, wellness, disease trajectories, and outcomes. And this health data was coming from a variety of large sources, such as a mixture of regional, national, and cross-border initiatives, e-health services and research infrastructures, and centralized and federated architectures. So there was a need for an alignment to deal with the challenges as we saw them. And this is a variety of different kinds of data offerings, different data standards, different permitted users and uses, different access terms, different interpretations of GDPR, and a realization that whilst COVID-19 had brought many advances, these might be temporary only, and we might have backtracking when the pandemic ended. Coupled with the multiple public attitude surveys generating mixed messages and sometimes confusing public opinion. What we know is that both industry and research need access to this health data. So our stakeholder engagements involve two roundtables held in the autumn of 2020, developed and run by DHS and IHD in a neutral and independent way, sponsored by Johnson & Johnson and Microsoft, and attended by at least 27 multi-stakeholder participants from industry, academia, health professionals, patient representatives, as well as DG Santé and Connect officials who both contributed to the events. The recommendations focused on two things: trying to influence the architects of the ambitious European health data space, and also to provide guidelines and good practices to be inherited by infrastructure projects to help grow alignment across Europe. So what were the conclusions of the roundtables? Well, we created 7 calls to actions, which you can see on the screen now. The first call, and by far the most important, was to raise the digital and data literacy and skills of all stakeholders. 2, to generate value and trustworthy real-world evidence acknowledging that the analysis methods needed to reflect the different nature of real-world evidence from RCT evidence. We needed to join up the sources of data, and to do this, the third call was to accelerate interoperability around Europe and globally. Fourth was to win public support by demonstrating the benefits to society from data access, use and reuse, and really to tangibly demonstrate in clear terms the benefits to patients, citizens and society as a whole. The fifth call was to adopt a risk stratification approach and to recognize the context of data and not just treat data in isolation as trying to place it in a vault, because anonymization ultimately reduces the value of research data. Six, and closely linked to this, was building a rule book to safeguard and protect citizens. And then finally, call to action 7, which was about adopting a transformational approach to health data. And if you like, treating data as a utility and recognizing that it's a societal good. And at that point, I'll hand back to Dipak.
Bleddyn, thanks very much. So we felt that the 7 calls to action had achieved something useful because they raised up the importance of addressing all of those things. But we also recognized that there was a need to go further than we were able to do in that year. And so we picked numbers 4, 5, and 6 in that list, clustered them together as a new thread of work to take for a deeper dive in 2021. I should also say that we didn't ignore the others, and there's another bite that we have recently taken on the next set of calls, which we'll tell you about on a future occasion, but today that's a mystery. Today I want to focus on numbers 4, 5, and 6, and what we wanted to do was to really explore in more depth what are the acceptance criteria for societal trust when it comes to using health data? What are the characteristics of our collective behavior with data and decisions that people might make about granting access and complying with the GDPR that would really make it possible for society to be confident and trusting in all of the many, many uses of data that we all know are important. So we convened, again, a wonderful multi-stakeholder expert group, and we divided them into 3 working groups to go into deeper dives. And they had a pair of meetings and also some work in between meetings online, which resulted as 3 consensus papers that we've packaged up as a report. And I noticed, Bleddyn, we forgot to correct, now being finalized as a report, now have been finalized as a report. And Bleddyn will tell you at the end how you can get hold of that report. So with the next slide, I'll just go through those working groups very briefly. You can see them on screen, but what we'll do is we'll leave this slide up just for a few seconds while I tell you what the 3 groups were. And I will invite the 3 panelists that we're delighted to have with us to tell you a bit more. So working group 1 really focused on how could nominated data access decision-making bodies like data permit authorities, which are being established in a number of European countries, best define the rules for data access, and also how should they provide public transparency about the decisions they've made and what happened as a result. And in a few moments, Nigel will tell us about that. Working Group 2 looked at how best to promote the development and adoption of a European multi-stakeholder compact about responsible data use. And I will ask Elena to speak to that working group. And maybe, Elena, when you start, you could also tell us what a compact is in case the audience doesn't know. And then the third working group looked at the experience of adopting the GDPR so far, and in particular about the difficulties about interpreting the GDPR regarding health data reuse. What might a more proportionate risk-based approach look like? And are new instruments on the table, such as the Data Governance Act, going to alter that possibility? And Jesper will summarize what he took from that. So I'm going to now turn to our three panel members one by one. And in each case, they're going to give you a personal take. What is it? So we're starting with you, Nigel. What is it about Working Group 1 that caught your interest, and what are the things that you particularly feel were positive about what we were able to achieve? Over to you, Nigel. Thank you.
Thank you very much. Hello and good morning, and thanks for the invitation to participate today, Bleddyn and Dipak. So our first group was looking at transparency and trustworthy decision making. Again, like all of these subjects, incredibly complex, particularly when we're talking about health data. This group, I suppose, specifically focused on infrastructure for the big beginnings of our look at this subject, in terms of where things may go based on current trends. And I think in particular, one of the things we were very interested in focusing on was the establishment of so-called data permit authorities, or DPAs. And a good example of those are things like FinData in Finland, or the French Health Data Hub, obviously in France. These are a small number, of course, and majority of member states don't have these types of infrastructures. But they do point to possible options going forward in the future in terms of how to support effective governance, which is balanced, I suppose, between protecting citizens and patients in terms of privacy and security and trust around the use of their own data, and importantly also to meet the needs, both in terms of clinical decision making, but also governance for research purposes as well, which will be multiple stakeholders involved in areas of interest for research. I think where we landed in terms of looking at these types of infrastructures and where they also align with, as you said earlier, Dipak, GDPR and various other requirements in the European Union, are, I suppose, a number of recommended actions based around transparency, consultation with key stakeholders, and clearly also involving the citizens and patient groups, of course, as well. But also looking at transparent terms and conditions that are required to help manage this process of generation of data through to the interest in using that data by various different stakeholders. And there could be a number of offshoots from this in terms of, I think, creating, for instance, inventory of requests, a kind of learning system, if you like, in terms of helping the community understand what is appropriate, what is inappropriate, where there has been maybe, shall we say, an easier path to approval in terms of certain types of research or requirements for data use. I think important to reinforce, of course, that individual data in itself, for most areas of research, is not that helpful. Maybe outside of rarer diseases and so forth, we're really looking at large-scale cohorts of data that gives us insights, signals and so forth, trends, all those kind of things as well. But we still need to balance this in terms of individual citizens and patients, and particularly based around trust, but trust is based on trustworthiness. So people need to be able to prove that they're trustworthy to be trusted. It's not just a one-way street in terms of relying on individuals to have trust. And then after those two aspects, the third aspect, which again fits into this whole area of data permit authorities or similar kind of structures, is the need for the ability to have reliance on systems. And a good example of this is that quite a lot of data that's used for research, we as individuals may not even be aware of today. They may be used by other third parties for research and so forth as well, that are beyond our immediate kind of scope or foci or locus of influence. And as such, that increases our reliance on systems to protect us. And therefore, the kind of infrastructures which may be enshrined in things like data permit authorities or similar need to ensure that they support trustworthiness, it's transparent, bidirectional, and indeed that the systems in place have an ability to be relied on in terms of confidence from us as individuals, of course, and from organisations' point of view, that governance is appropriate, that we are protected, but we're not reducing or indeed risking research and innovation and so forth. It's a very tricky balance. Clearly, more work to be done, but I think one of the key aspects, I think, from this particular group's output in this roundtable was very much around transparency, which is obviously critical. Thank you, Dipak.
Nigel, thank you so much. That's a really lovely summary of that group, which I was also part of. As you've reminded me of many of the facets that we chewed over together with our colleagues. Elena, can I come to you to tell us a bit about your working group, but starting with what is a compact, if you don't mind?
Yes, you also asked what was personal for us in this working group.
Yes, absolutely.
So, let me start with 2 points, and I'll get to the compact. First of all, I think if we're true to our mission to really look at a digital health society for all, we really have to have working groups, roundtables that reflect that diversity, and you succeeded in that mission. So I want to highlight the fact that the diversity of participation, representation, point of views made it a very rich set of discussions that even with intense and busy agendas, it was really a pleasure to be part of. And what was personal for me was that we had a finality on how to return benefits for the share of health data, because we talk a lot about share this, share that, but in the end, people feel very private about the health data. So explaining the fact that there is value for them, for their dear ones, for cohorts of patients that look exactly like me, like you, like them, was an important finality for me as an advocate when I think about the role of data to save lives. So with that in mind, I thought that the idea of a soft regulation, soft legislation approach, the idea of a compact that would support responsible use of data, transparency, accountability, communication, that soft regulation approach is definitely one that is more dynamic in its nature, but also is prone to a more consultative approach in terms of, and almost like an iterative approach, because we need to really reflect and mirror the fact that both science and technology as the two ingredients of precision health in the future are moving extremely fast. So we need to have high velocity. Now, one of the things that was very clear in the roundtable is that the intended benefits of the data need to be really clearly shared for all constituency, clearly communicated. And that was the case both in the discussion in terms of the primary and the secondary use of data, which are two very different conversations. There was also clarity on the fact that we need to touch both access and use. They are two different things. So the availability of data from all the data sets, beyond the systems of record and the gold rush to put everything into EHR, lab systems, and PACS and so on, going beyond that was the key to look at the individual in a holistic way. So let's not forget that we are aiming for longitudinal health records. There was the other element of reusability, and therefore that speaks to the opportunity of inclusion and also a global opportunity to think about these discussions that we are having for the health data space in Europe. How would that apply if we took a global perspective? Because it was mentioned in the beginning, health as we have seen, as no border. And we spoke about lessons learned from the digital passport. So the fact that in emergency time, there has been a real way in which we could have mobility of data, but we could also have standardized way for the passport agreed very quickly. And we could have the credentials, meaning on the receiving end, someone could validate that those data were in accordance to the standard established. So that we felt that gives both hope, but also an opportunity to build on it, to take lessons learned from it, and also make sure that we learn from experiences across member states, different stakeholder groups, and also, I would say, transatlantic with global initiatives. I would like to close on the fact that we have touched on privacy preserving techniques, distributed machine learning, making sure that we really stay close to the needs and expectation for trust. Because without a common basis of societal trust and an understanding that societal trust needs to be respected, there will not be a health data society for Europe. And then that common basis would also include, and we've discussed a lot about interoperability, corralling around consensus-based standards like FHIR and others that really will enhance the mobility and the interoperability of data in a very data-intense setting. So I hope that I touched on all the key points. It's been really fantastic. So I wanted also to congratulate you in this effort, really worth doing. Thank you.
Elena, that's lovely. Thank you very much for that really interesting and rich summary of your group and the topics that were raised. Jesper, let's turn to you and your group. Over to you.
Thank you. And thank you for giving me the opportunity to talk about some of the discussions. Obviously, this being a personal reflection upon this, I would just highly encourage people to go to the report and read all the details. I'll lot more into it. But some of my key takeaways from the discussions we had were really that there was almost like a consensus around the group that, yes, we've had GDPR in place for the last 3 years. And all what we're starting to realize now is that interpretations around it don't really seem to be that harmonized. Maybe we're just having those initial learnings that we need to take from here, just realizing that we need to get better at this. But I think there's a little bit of urgency as well. We want this to happen really fast. So how do we get there? I don't think that was really with a recipe and resolution there yet in our discussions, but we were looking at Data Governance Act and AI regulations that are, to me and to our discussions, much of an enabler of pushing forward that we need to make better use of our health data to speak into what we as a society really needs to have enabled, and this needs to come to some harmonization around GDPR. Now, reality is that GDPR is really what will be there to harmonize our approach. If you go into the different legal settings in the different member states, you will easily come to realize that local legal regulations in place are maybe what is driving some of the non-harmonized approaches. So I think there's a lot of discussion still to be had there, where the Data Governance Act can eventually drive that even further for harmonization. But as we talk legal in this, and I'm not a legal scholar by any chance, so I'm bioinformatics and computer science as a background, and obviously what I then look at is, how does technology play a role in this? And I think we had the discussions earlier presented by Nigel around the data permit authorities. I think that's an organizational way of putting technology into place where then trust the lineage, you trust the frame under which data is being worked with. That influences your risk around the confidentiality of that data if that gets kind of compromised or can be controlled. But we also briefly touched upon that there's actually technology in there we need to consider. What role would synthetic data sets, differential privacy, homomorphic algorithms, distributed machine learning, what roles can they play in the future? I think there's still to be defined potential in those technologies that can keep data safe in accordance with GDPR, yet open the machine room to access data that would otherwise not be accessible. I think so. There's still work to be done in that space. We talked about the FHIR interfaces. I think we got the technology to do the messaging, to do the technology operations. Let's get on with it with European health data space, the pilots, and what else is going on in terms of modernizing our use of data in a federated manner. But really good discussions about GDPR and what that can do for us, the challenges ahead. I urge everyone to have a read for what is actually quite readable piece of text in the report. So,
Jesper, that's lovely. Thank you very much. Now, I'm going to come back to you as panelists in a few moments with a couple of other questions, but I would actually like, first of all, and I hope I've remembered our plan correctly, Bleddyn, is to first go to the audience. You better just nod and check that I'm doing the right thing. Yeah, okay, good, that's all right. So audience, please, I hope you're already awake, so I'm not going to say wake up. But what I will say is start flexing your fingers, because we want you to respond to a poll. So the question really is about a quid pro quo. What do I mean by that? So an issue that our experts grappled with in more than one working group is how should a large-scale data user, such as a pharma company or a large ICT company, or academically a major funded research grant-funded proposal, contribute back for having gained access to data. Elena mentioned about shared access and sharing. So a phrase that Nigel likes to use for this is quid pro quo for data access, and I think it's a perfect phrase for what we're talking about. But, you know, should a large data user pay for data, cash? And if so, how much should they pay and to whom? But yet, on the other hand, the idea of a health system selling its data, selling patient data, is unacceptable to a lot of people. So there's a real tension in this space. And what we have is a few options that we'd like you to give an opinion on. So what we have is 5 possible quid pro quos. And what we would like you to do is to score each of those 5. How acceptable would each of those be in your opinion? So everybody's giving a personal opinion, and your score is 1 if you think it's pretty unacceptable, and your score is 5 if you think that it would be a very acceptable option to put into the ring as part of a quid pro quo equation. So I just need now to check, Bleddyn, are the audience able to see those 5 options? Should I read them out?
So they can, if they go to the streaming button on the platform and click on it, they'll see the word poll. And if they click on, the questions will come up, and then they can complete the poll. And then when we have, we'll give them sort of 10 minutes to answer, and then we'll put the results on the screen.
Okay, for the sake of our panelists, though, who don't have that view, I will just read them out. So the 5 options are paying on the basis of volume and quality for the data, paying on the basis of expected future sales arising from data access, contributing financially to the cost of curating and accessing the data set. So you're contributing to the machine rather than for the data, contributing financially to the setting up and running a data access infrastructure. So that's offering money into a pool rather than paying for particular data access, and contributing your own organization's health data set for others to use. So the quid pro quo is, yes, I'd like other people's data, but you can also use mine. So all those 5 are for audience vote, please. Please go ahead, and panel, I'd like you to not at all respond to that for a moment. You're not allowed to say about that. But I'd like to ask you a question, if I may, all 3 of you. And that is that we know that a lot of the issues around trust and also interpretation of GDPR, as Jesper mentioned, are kind of within country. People trust people they know, local people, local organizations, names, organizational names, and also, as Jesper mentioned, the interpretation of the GDPR is often anchored in national decision-making as well. And Nigel mentioned data permit authorities being established at a national level. But the future of examining data and gaining inferences is likely to not be at a national level, because we're going to want more and more precisely specified patients for precision type thinking. Those precisely specified patients will be too few in each country. We really need to scale and learn together, and things like, I think, Elena, you mentioned that the COVID passport, this was an example of European collaboration. So I would like to ask you panelists, how do you foresee European cohesion? I mean, Elena, I think you actually mentioned global as well. So I'm open to whether you want to be even bigger than me. I'm thinking European, but push me if you like. What do you think are the likelihoods and the ways in which we might get multi-country cohesion around the whole issue of trust and the topics of your groups? I think you just have to wave your hands, forget any icons, just wave your real hand like this if you want to be the first to jump into this topic. Okay, Elena, jump in.
I'm happy to. My reasoning would go that we definitely have a future in which data collaboration will take scale, because the developments around new therapeutics, new drugs, precision health overall is as much a scientific as a computational challenge. That means it's data-driven. That means you need to reflect a very inclusive profile of the patient that we want to treat, and at the same time, a very personal profile. So we need those data collaborations to be as wide, as inclusive as possible. Now, there is a real challenge in terms of the diversity of regulatory landscapes, which we cannot ignore and we shouldn't ignore. So starting European, I think, would be a fantastic achievement. And then from there, established other collaboration. Now, so that is my hope and the vision. And I would say that if we can explain the privacy preserving capabilities that can be embedded, right? In many ways, Jesper mentioned some of the incredible advances that have been made. If we can really focus on the fact that privacy is an area of innovation and therefore as a driver of trust in the way data are used, I think we would go a way forward. And oftentimes we talk of the other side, which is when privacy or security are breached.
Thank you, Elena. Nigel, you want to come in next?
Yes, thank you. No, thanks very much. It's a very interesting question, very complex, of course. I think first and foremost, we shouldn't assume, because actually it's an incorrect assumption that this is a level playing field. Even just look at the 27 member states in the European Union. There's a massive diversity and a heterogeneity in healthcare provision, let alone digitalization and healthcare systems and so forth. Unfortunately, health data has been kind of conflated with numerous other uses, including with social networks and tech titans and so forth. And this led in some respects to the GDPR, I think. And of course, it is probably the ultimate personal use of data, of course, in terms of healthcare. It's most immediate to us in our lives, and particularly when we're sick. I think therein there lies a challenge that health data itself has not been, even by regulators, been considered wholly as special. It's been, even with GDPR and various other initiatives subsequently in legislation and so forth, it's actually hardly got a mention in some recent legislation. It needs to be viewed as a particular speciality in its own right. I think secondly, as I mentioned earlier, what are we trying to protect and what needs to be protected against? Actually, from a research point of view, from my point of view, I have no interest in the individual identity of anyone at all. In fact, I don't want to know. It's going to cause me more grief than anything. And there's no real reason for me to know. I do need to know that someone is an individual, maybe because I'm linking records, or maybe because of certain nature of understanding natural history of disease or whatever across time. All sorts of reasons. So I think one of the real challenges, of course, is that we are often talking about perceptions. So we need to understand what's perceived risk versus potential actual harm and actual, and actual real life risks. Most health data breaches are actually from healthcare providers. I think most of the statistics suggest that internationally as well. So, I don't think we have got a very clear picture of what it is we're actually all talking about. Most of what we talk about today is based on assumptions, and it's based on assumptions of what we think are risks versus actual harms. And I think that needs to be tested. There was a very celebrated case in Massachusetts in the late 90s where they went to a full consent model for everything, not just healthcare, but whether or not your priest, for instance, could divulge information related to your confession, or all sorts of things. I mean, numerous things around outside of health as well. It was a disaster. It was actual Massachusetts citizens who said, "We do not want this. This does not work." And in healthcare, which is transactional by nature in the Western model, i.e. you see a specialist or the blood's taken and goes to a lab and results come back, and I'm overly simplifying. But, if you had to consent every single step, healthcare would collapse. And we've been doing this for more than decades. So I do think we have a really strange position now, which is really focused on, risks around our data. Whereas actually, even before digitalization, there were breaches, large-scale breaches, even with paper-based records. I don't think it's that this is a very balanced argument actually in between risks and actual harm and actual value. In terms of what are we trying to achieve. If we had introduced certain draconian steps around data during the pandemic, I wonder actually if bearing in mind the right data has not been in the right place at the right time to answer questions in terms of COVID-19. And in fact, that's not unique to pandemic. That's a problem with all diseases. Actually, we could create more harm than good by introducing, and the pendulum swings too far. So I'm maybe controversially not a great proponent on some of the aspects around consent models and so forth that are being suggested, and particularly things like data altruism, which I think is a bit of a misnomer. So I actually think we need to be very clear about what it is we're talking about before we even get to the point of trying to get harmonization between international states.
Nigel, thank you. Jesper, do you want to come in on this question? You also care a lot about the European dimension.
Mm-hmm. And I think one of the things that keep coming up is the heterogeneity. Nigel elegantly just pointed to that here in terms of the 27 member states. I would actually like to flip that around. Do we really need 500 million of people being completely harmonized on data in order to use it? Maybe that is what you would often in other studies call an overpowered study for the question you may have. So maybe heterogeneity really is a benefit that we should make use of. Realize it will be around for the next 10 or 20 or how many years before we even get things fully harmonized, if we ever get to that point. But it actually tells us about personalized medicine in a completely different aspect, where behavior, where the socio-demographic factors, where the treatment standard of care is playing into it, alongside with just our behavior, our microbiome in phenotypically terms that we can see it in the data, and the genome as that evolves over time. So maybe it's an opportunity where different questions should be placed in different data repositories. And as you start to incentivize as well, I think the use of those repositories, you also start to speak into personalized medicine. You're taking from the regulatory perspective where I'm coming from, where personalized medicine is going to be more and more so. Is that truly arriving on our doorstep with a randomized clinical trial? I don't think so. It really sits in those big sets where it can start to single out some of those patients that look alike due to phenotypic, genotypic, behavioral factors. Then suddenly the heterogeneity actually makes sense. Yes, I need to harmonize on the technical level in order to address the data and understand what's in there. but it really incentivizes the entire value chain to me. From a regulatory perspective, we need it on the behalf of the citizens in Europe. As a citizen in Europe, I need to make my data available because it actually helps me together with other citizens that may be like me in order to address the most relevant treatments, the most relevant medication needs, the medical devices I should be using, and so forth. Incentivizing, benefiting from heterogeneity, really creating those massive numbers of different clusters of different patients who are, I think we get a great opportunity in front of us, not necessarily challenges alone.
Jesper, thank you. Again, very rich, interesting food for thought. Nigel, I got the feeling you wanted to come back with an additional
very quick
reaction.
Question.
Yeah,
if I may. So my point really was about. So I don't disagree at all with anything Jesper's commented on in terms of the heterogeneity of individuals in terms of research requirements, and I think that's absolutely correct. But actually, if we're talking about utilization of real-world data from, mostly from clinical care, not exclusively, of course, but that's where we tend to focus at the moment to the low-hanging fruit. I think one of the biggest challenges we have is the heterogeneity in outcomes. And actually, if I'm sitting here in Belgium, Jesper's in Denmark, and Elena, forgive me, I'm not sure whereabouts you're sitting at the moment, which country, but
I'm in Belgium with you.
Oh, in Belgium, okay. So two of us in Belgium, and then Jesper's in Denmark, of course. Obviously, Bleddyn and Dipak in the UK, but and then maybe others in the audience from Southern Europe, for instance, or Central Eastern Europe. And if you expand that globally, our outcomes if we unfortunately have to be treated as the same disease, putting aside individual nuances as us as people, are all different. And in the 21st century, that doesn't make sense, does it? I mean, we should be ensuring optimal outcomes wherever you are on the planet. Maybe for me, that's actually the test of innovation for healthcare in the future, is that wherever I go, I'll get similar outcomes from my treatment based on, relatively similar matched individuals. Yes, okay, that's probably maybe a pipe dream for the foreseeable future. But that's probably an acid test of whether all the innovations that come together ultimately result in improvement in healthcare across the board, are kind of leveling up. So when we're talking about use of data, It's twofold. It's clinical decision making and it's for research. I definitely agree on heterogeneity in research, but on the clinical decision making point of view, it can't be right that our outcomes are so different just purely due to things like geography.
Very good. And it points to the fact that, come in, Elena.
Just one very brief thing, which is I do agree with what Nigel just said. However, it takes the conversation to a much broader level because that disparity of outcomes really is often directed by a different maturity of the health systems, capability, resource availability, incentives, and so on. So we really talk about the foundational the foundational outlook of health systems, how resilient they are, and how resources are allocated, which goes much beyond the data conversation.
Great. Thank you very much. I think there's no doubt there's a huge amount of learning still to be done from data. And a lot of actors, whether in the health system or the research system, need to be contributing to that learning, sharing the data and sharing the learning. Now let's turn back to the poll. So I hope that from the panelists' point of view, you're able to see in the chat a link that gives you the ability to review the results. So if you haven't noticed it, please quickly do that. Bleddyn, how do we engage the audience in that? Does the audience already have access to these results?
I think we'll be able to put up the results of the poll now on screen so that everybody who is attending will be able to see them. So if we just wait a couple of seconds, I think the poll should come up. Here we go, I think.
And maybe Dipak, like in the Oscar, you can
announce it. Well, I've not had my Oscar training, I confess. I'm sure that they do get trained. But what I suggest is, why don't we take a look a little bit collectively at questions 1 and 2, because they're both about paying. They're about putting money in on the basis of data, not infrastructure, not costs, but actually saying paying for data. And there were 2 metrics. One is you pay for the volume of data. In other words, you pay by the kilogram for the data. And the other one is you pay on the basis of opportunity. You know, how much money will you make from the products or services that you can eventually exploit once you've got the data. And so those 2 charts, and I'm not sure if the person who is controlling the screen could allow the scrolling maybe to go up or down a little bit so the audience can see both questions, just 1 and 2 for the moment. Reactions, please, from any of my panel colleagues to that. Are you any surprise here? Remember, 1 is pretty unacceptable, 5 is pretty acceptable.
Yeah. I think I'm surprised that question 1, that there is perhaps, you know, the largest answer is number 3. So people are prepared to see payment. I thought we might see the highest score being 1 or 2 for that question.
Mm. Well, it's difficult to interpret, because that could be, I'm not swayed either way, being sitting at 3. You know, it's neither a yes or neither a no.
Yeah.
So 3 is on the fence, is it?
Possibly. It depends on your interpretation of the data.
But it's not a no, which is what I was thinking it was going to be, if you're like a 1 or a 2.
It means you could be swayed potentially either way, depending on what what the arguments are to support that. Whereas in 2, I suppose it's clearly spread out all over, but it's a bit more polarizing, I suppose, in terms of future sales and so forth. And maybe that's not a surprise based on previous discussions that have been had over time.
Well, and I think it certainly reflects the round tables, where we recognise that there were some polar views on this amongst us, and that this was actually quite a controversial topic, full stop, if you like.
Yeah. And yet it probably makes sense then in the later ones that people are more persuaded by, you know, where the costs contribute to things like infrastructure, and creating and accessing the data and in infrastructure and so forth, and the last one was contributing data sets for others to use. These are incredibly, particularly number 5 is incredibly topical about open access, I suppose, and, you know, quote unquote sharing. It means many things to different people, but sharing of data and so forth. But, you know, just being able to utilize, for instance, publicly or government funded data development or generation should be available for all. This is a common thread at the moment. So these probably 3, 4, and 5, and the questions are maybe not surprising, considering where kind of the discussions are.
But let's stick to 1 and 2 for the moment, because it is probably the hottest. So not to stop you, Nigel, but just I'd like Elena and Jesper to see if they would like to react, but especially to this whole idea of paying for data, you know, by the kilogram or by the possible you know, financial benefit downstream, business value.
Yeah, I think in a way, the moment in which we say paying for data, we take the conversation to a whole new place. Because the whole problem with sharing data has been twofold, right? The fact that somebody would actually know things about me that would, quote unquote, allow that organization to retaliate and put me in a weakness position. So information asymmetry, in fact. And the second thing, which is somebody taking commercial advantage of me for advertising purposes, for example. That's the model we know. When, from a Microsoft perspective, when we started to look at open data initiatives, open data campaign, the North Star was really to look at other ways to extract utility, meaning value from data in ways that would benefit society, the individuals, and the common good, being it, more resilient health systems or faster scientific innovation. So you find me personally very geared to look of what is the value that I get back in the quid pro quo versus what is the money element. Mm-hmm. And I think that if we keep that element of, sharing my data, I can really tangibly see how you get me to a cure faster. Or if I take a very sensitive topic on the vaccination side, the many patients that have been experiencing adverse events and didn't really have a feedback loop that was available to share their data, because the medicine authorities at national level are not empowered to do that. But the feedback loop towards the pharmaceutical would have been extremely, extremely effective. And people that are in those situations want to do that, and it is a matter of civic responsibility. So you find me middle cold on the money side.
Okay. Bleddyn, you want to jump in?
Yes. So we've had an interesting comment from Susan Kelly in the audience about that the responses should be stratified by audience, i.e. SMEs likely to feel differently from pharma. And I think to reassure the audience, this was intended to be a little bit provocative, just to test the water, because actually we feel that this whole area is something that's worth a deeper dive. So Susan, I absolutely agree with you that we're being quite simplistic about how the questions are asked, just because of the constraints of a poll of this type in this shorter panel. So I think this is a topic that Dipak and I think we could easily see a whole round table on, doing a much deeper dive into some of these things to better inform the audience.
Okay, so you've let the secret out, Bleddyn, that Bleddyn and I want to do a deeper dive on this deeper dive topic. And that's why we put it in the poll, to wake everybody up to the importance of it. But Jesper, can I come to you? I mean, we've got this slightly polarized poll because we've got two topics, two questions about paying, really cash on the table, and then three that are much more about contributing, being part of the game. Deliberately. And then we've actually got correspondingly quite different patterns of audience reaction to those. What's your take on that?
Well, I think paying for data is already happening. And in a number of countries, it may just not be that clear to people that's actually what is funding the infrastructure, funding making the data available. With the Danish Health Data Permit Authority is actually what researchers do. They pay for access to their research environments that can actually research on the data. Obviously, someone has to pay for that infrastructure to be in place and quality controlling the data and make the data flow. And I think there's similar systems set up in other Nordic countries and across Europe. As a matter of fact, as individuals, we also get payment for some of our data. If I use something on my phone, whatever app I use, if I consent to that, obviously I get the app for free in many instances. So I think we are already paying. It really shouldn't be that controversial. What is really controversial is we may not be realizing that that's actually what's happening. Mm-hmm. At the end of the day, none of us are able to work for free. We would love to. But we still need to have food and a place to live and a house and some warm during the winter. So obviously people need payment to do their work, right? And reality then is whoever volunteers to do this needs to have something to live off from. And obviously that then keeps the cascade. Payment has to be part of it for data. It's just about making it transparent and trustworthy, and also making it clearly a democratized process of how that is being done, right?
So that's very interesting. Bleddyn, do we have any more questions?
Yeah, so we've got 5 minutes left, or just about. So I thought we'll pick up some of the questions from the audience. So I have one. It says, it's obvious that the DHS and IHD are producing worthwhile reports and running a great event, but how will recommendations be implemented in Europe? Too often, good intentions don't get translated into action. So what do we think about implementing some of our recommendations? if I try to start that, the original calls to action were as I explained, the 7 areas that we thought needed to be addressed, and then roundtables 3 and 4 have, as using Dipak's language, deep dived into them. So we've gone to the next step from the original recommendations to drive into greater detail about how some of this stuff could progress, what further implementations could happen. But understanding that, what do we think are the possible next steps from the deeper dives?
I would say I would love to see some more work going into the compact. I think that's a very practical, hands-on, yet collaborative and quite inclusive way to suggest a way forward. So that would be one I would recommend.
Yeah, and as somebody in the same working group as you for that, what we've done is we've created a series of checklists, if you like, about what a compact would look like. So it's a short step, perhaps, to see a large group of multi-stakeholders deciding to draft an outline compact. So we could certainly see ourselves doing that.
If I may, I think, inevitably this will have to come from bottom up and top down. So I think in the light of where we are currently with the European Health Data Space developments and proposed legislation in the new year and so on, engagement from the Commission down, at least in the European setting, is critically important. But it's absolutely imperative, of course, for change that there are a number of champions and that there's a wider group of sort of key stakeholders, I suppose, that would like to adopt this. Probably, again, starting slightly smaller and wanting to expand. You couldn't imagine trying to do this, ubiquitously and all at once across the whole of the European Union, but certainly some member states may be able to respond to this. It would be good to get a balance of those.
Jesper, any thoughts from you?
Yeah, I think it goes to the composition of the work so far and the output, and I actually think this serves as an important blueprint alongside with TEHDAS, European Health Data Space pilots, Darwin EU, you name all of it, right? I think they will mutually influence each other, and this is an important piece of those crystallized discussions into these suggestions for the way forward. So I'm rather optimistic about taking these things and make them as actionable activities within the different relevant fora to get this progressing. So,
if I may add, one very, very quick last point. Don't waste a pandemic. Actually, there's a lot here that's topical that could be reflective of where we are regarding the pandemic, but certainly where trends are accelerated by the pandemic, we should certainly utilize that too.
I think the other thing, briefly, just to mention, Bleddyn, that we were quite strategic in inviting into our multi-stakeholder roundtables people who could also, in espionage terms, be called moles. We invited people from the European Health Data Space. We have people from Darwin, people from Eden, some of the big industry giants and influential lobbyists. So we have turned you all into our agents of change and provocation. So we expect you to all go away and promote and so on. But obviously we have to look at more cohesive action as well. And that's something with Bleddyn, we need to take that as a learning point to figure out what are the best ways we can reach some of the top level decision makers in this area. Now I'm conscious of time. Bleddyn. Do we now need to hand back to you for that final?
Yes, please. So I think, first of all, on behalf of Dipak and I'd like to thank all of the panel for your time and your great contributions this morning. We are very grateful. I think, I'm sorry we've not been able to take some more of the questions that have been appearing in the chat, but I can assure you that in addition to looking at how we take this forward in tangible terms, we also try to look outside of Europe and look at some of the initiatives that are taking place in other parts, whether that's in North and South America, whether it's in India and Africa, or indeed in the Far East. So we're conscious that we shouldn't be too insular and entirely focused on the European health data space. And in the chat now, you should find the links both to the calls to action and to the Roundtable 3 report. So with that, I thank the panel, and we will move on. So thank you very much indeed.
Thank you, panelists. And thanks, Bleddyn, for DHS hosting this event.
You're very welcome.
Cheers. Bye.
So, bye-bye.